Right, what are we getting into now? Looks like we're getting into a little bit of the groin strains. Oh man, I got a sweet song playing in the background here. I love this version. It's The Weekend by J Flaw. Fantastic. But let's go ahead and get into our content right here. I almost feel like having this playing in the background, just nice and quiet. But all right, we're here to talk about groin strains, a fantastic injury. You're going to see this one all the time. So a couple of key things to get here. I see this in hockey players. We do stuff for various NHL teams, and a super common injury. So stretch or tear of the adductor muscles, usually in order of occurrence, most commonly adductor longus. Adductor magnus, not enough people pay attention to this muscle. It is a big, strong, powerful muscle that has a substantial hamstring portion that goes all the way down to the adductor tubercle, adductor brevis, and then pectineus. These shorter ones that kind of get closer to a flexion type action, not usually involved as much for these groin strains. Groin strains. So we're looking at there, pulled groin, adductor strain, different names for it. So basically the primary mechanism is overstretching. You've reached the structural limit of the tissue. It can't handle it anymore and it tears apart a little bit. The problem for these conditions though, are that they become chronic issues for players. So they get this one injury and then they have this chronic groin pain associated with it. And we're trying to prevent the chronicity of this condition. So it's often secondary to a sudden change in movement. So a cutting or legs slipping out to the side or whatever it is. If you don't have good cleats, if you're, I like to do a lot of barefoot running sports. So if you're running around and slipping around on your feet a little bit, it can happen there. Usually starts as a dull ache in the groin. Healing can lead to chronic problems. Complete ruptures or avulsions are pretty rare, but they can happen. But if you've seen this in a more severe injury, you'll actually see it as, well, substantial bruising in the area as well. And that's a pretty nasty injury itself. But where are these adductors? We should just be aware all on the medial side. And of course, adductor longus here, where I've drawn the tear in, adductor magnus, you can see at the back. I just can't stress it enough. If you haven't looked at a cadaver dissection in a while, we have videos of this up on our website. Adductor magnus, big, strong muscle, major player for stabilization of your hip joint and the thigh itself. So incidence, approximately 2.5 of all sports injuries, way more common in hockey, soccer, karate. I see it in jiu-jitsu all the time as well. You're doing a lot of gripping with the legs and trying to stabilize yourself. More common in older athletes. Oof, that's me right there, due to reduced elasticity of the connective tissue and, dare I suggest, a little bit of muscle weakness that happens with time as we get more fibrous as we age. Seems to be no gender difference in the literature. And risk factors, it's pretty much sport related. So structural issues, number one, could be a lack of flexibility. That's kind of a catch-22 because often you don't want to be super flexible, so you have a maximum power range, but that lack of flexibility when you're overforced, the power of the tissue can resist, can lead to the injury. Foot and leg misalignments potentially could be there, leg length inequalities, muscle weaknesses, even prior groin strain will be the number one risk factor, of course. And then, of course, overuse or inadequate warm-up. You've got to warm this up, but it's not long-held stretches. And I'm going to go on the soapbox here a little bit. Every sport, every NHL team, every WHL team, every hockey team that we work with, we tell them, don't do that standard long-held stretch at the very start. You're better off standard hockey stretch where you're on your knees, leaning over top with your hockey stick. You're better off just leaning from side to side, in and out a little bit and warming up in the activity than trying to hold a long-held stretch. So history in your assessment, you're looking at medial thigh pain, and they can usually pinpoint it. They can put a finger right on it and says, yeah, it hurts right here. In severe cases, you might actually even be able to palpate the actual defect in the muscle. Now, having said that, as a male practitioner working on female patients or whatever, this is an area of extreme sensitivity, and you have to get informed consent, especially for this region. So not just your general consent, but just making sure, saying, hey, I'm going to be palpating up around your inner thigh, even along the bone of your pubic bone at the very front. If anything is too much, let me know right away. Is it all right? Do I have your consent to proceed with this hands-on evaluation? Be ultra clear on that when you're working in this area, just so there's no miscommunications there. The patient themselves may hear a snap or a pop at the time of injury. When we can go ahead and grade it as well. Okay, so if we have mild, they can usually walk, maybe the most subtle limp, but nothing too major. Everything is working pretty much normally. If they have more pain and weakness, now they're going to have a limp. They don't want to move their legs. Pain with stretching of the muscle, which will again be a catch-22 because we'll see that this is actually one of the treatments we're going to be doing for it, is stretching that muscle or contracting it in a lengthened position. And number three, that full rupture might actually be less painful. I would look for significant bruising in this area. as well as significantly altered gait and loss of function. And any kind, they would have weakness into adduction, okay, of the hip as you want to move them. Physical exam, palpable, possible altered gait, swelling. You might even see this bruising there. Palpation. This is the biggest finding right here. I've only said it 3 times so far, I think. You're looking for tenderness to palpation over the damaged tissue. Excuse me. And the nice thing about the inner thigh, there's not really that much else there. It's basically big muscles, no major vessels, no major nerves in that area. So you can go ahead and palpate in there fairly deep, big, strong muscles to stabilize our legs in our bipedal motion. What else? Active range of motion, pain during adduction with active range of motion or resisted range of motion, and then pain during abduction when you stretch the damaged tissue. Neurovascular is usually within normal limits. What do I say here? 30-90% of all groin strain injuries have one or more injuries that are missed or go untreated. Look for other pathologies. Absolutely key. One of my favorite expressions I learned in school was, what's the most commonly missed fracture on x-ray? The second one, because everybody pays attention to the first injury and doesn't look deeper. So take your time with your clients, with your patients, and look for other areas of injury that could be going on. So you could have hernias, avulsions, otitis pubis, iliofemoral. Well, you could have iliofemoral, but iliopsoas bursitis, osteoarthritis, labral tears, rarely septic arthritis. We'll come into that as a separate condition, whole separate video on that. Leg calve person, kids are always worrisome. When they come in with a limp or a groin strain, you definitely have to do a more detailed evaluation to make sure that they're going to be okay with that skiffy. Obturator neuropathy is pretty rare, but that is the distribution of the obturator nerve for its innervation. And of course, low back or visceral referral, GI, gastrointestinal referral patterns here you're looking at. Okay, special tests, pain with resisted hip adduction. You're challenging the muscles and it hurts. Pain with passive range of motion. Go figure. You might even do a resisted muscle test, and this I would use as an outcome marker. See how they are on the first day, test them again, the next treatment, test them again, the next treatment. Show them, empower them, educate them that they are getting stronger with each movement, right? Imaging, not really warranted here. I mean, you could do ultrasound to go ahead and look for the tear itself. But again, it's an extra procedure you probably don't have to do. If it walks like a duck and it talks like a duck, probably a duck. All right. X-rays, if you're concerned about other fractures or osteoarthritis. But if you're going to go down that OA pathway, you might as well say that this person is probably in their 60s or 70s, possible in their 50s, but usually not that common, unless they have a history of hip pain, in which case you might want to do it. And then MRI or CT could show you more soft tissue injuries, but again, probably overkill for the vast majority of cases. So that gets you through your basic assessment. We're going into management now. So as we go into management, key things to get: relative rest. That means don't stop moving it fully, challenge it a little bit, but don't give it ballistic loads or heavy loads because you could make the tearing worse. Usually your body will tell you, it'll give you that sharp pain that'll prevent you from pushing a little bit further. You want to avoid painful activities. You might consider crutches, but only short term, just as a brace for them to start walking around. You still want their leg to be able to swing back and forth and move it around, okay? Elastic bandages may give support to the adductors, so you could actually do a tensor bandage wrapping if you wanted as well. I've seen that quite commonly. Excellent techniques to use: massage therapy, winner, chicken dinner, right there. Breathing and relaxation. Don't go directly over the injury site during the acute stage, but work around it in areas of compensation. And of course, checking in with your client all the time to make sure that you're within their tolerance of pain. But mild, mid-range, pain-free range of motion could be there. Once you get into subacute, Golgi tendon releases can be there. Stripping or any of your Swedish techniques can be used. And I would actually suggest instrument assisted is when I would start using that as well, as in this subacute stage. So as long as it's not too painful or I'm not spending too much time on the injury site, I've had good success with groin strains and hamstring strains the same way. Chronic cases, you might consider other movements like more aggressive stretching, joint plays. You can do joint play all the way through here actually for most of this. And of course, instrument assisted again. Overlaying all this would include joint mobilizations, and manips could offer some benefit as well for areas of compensation, because as their adductors clamp down and lock down, their acetabular-femoral joint might not move as well, which may affect the SI joints, which may affect up into the lumbar or down into the knee. So again, a good detailed evaluation on our areas. Electrotherapeutics, acupuncture, all have potential to help as well. Surgery, rarely ever required. Again, this is not a usual surgical intake that's required here. unless it's such a bad rupture that you are sure they have 100% tear of the muscle, in which case they probably presented in the ER to begin with. So that kind of an injury would be, yeah. I just, surgery, I've not even heard of it. I had a patient yet in my 20 plus years who's had surgery for an adductor groin strain. All right, what do you do for follow-up? Here it says, do not stretch during the acute phase, first 48 hours. I would suggest in general, that's good practice. However, it's a more mild injury. You could give a light stretch and then work on isometrics. If isometrics are okay, they can develop that tensile strength without causing pain. Then you can start working on increasing the load to their tolerance. Again, do not overload this person. If you overload them so much and it causes more tearing, you're delaying their healing and you're probably making this more of a chronic issue for that person, okay? So we don't want to delay healing as much as possible. We want to challenge them in a safe, respectful way. So ensure the patient does not stress the muscles until the healing is complete. Not 100% true on that. What I would say is doesn't overstress the muscles, okay? So a little bit of light loading is going to be okay, but overloading can make chronicity out of this problem. Prevention, educate the patient on what actually happened. What, you mean my long-held stretch right before I go do ballistic activities might increase my risk of injury? Yeah, do not hold these long stretches before you go and move. Warm up the area, but don't give these long elongating stretches that are taking place. I see this in yin yoga practices all the time where they hold positions for 2 to 5 minutes. Not good. You got to warm yourself up into these, okay? Prognosis is actually excellent for full recovery, assuming they follow the correct appropriate rehab and you identified the pathology and contributing factors correctly. So what do we get? Development of chronic condition, definitely very common. And I give you some key exercises you might want to do. So what I find beneficial here, you can see right at the very start, is something as simple as lotus position, just laying on your back, feet together, let your legs drop out. This is a gentle stretch of the adductors. If that's too much, push your feet down a little bit further, and then you don't put as much stress onto those as you move. The next thing would be, simple foam rolling. This is the person's lifting up their lower leg to start strengthening the muscle. This with the ball is a little more advanced. Same thing with this pose right here. You can see the adductors being strained out there a little bit, but hey, if you're just standing, in fact, you could even do this right now. If you're just standing, stretch your hips out a little bit and just rock from side to side. Oof, I had a pretty good workout yesterday, so I'm pretty sore in there, but that's a nice way for you to start to gently mobilize that tissue and help those fibroblasts and myoblasts lay down collagen and muscle fibers along directions of tissue tension. And remember, you have to load a tissue to heal a tissue. So if you don't load it, the scar tissue formation winds up going in all kinds of different directions. But if you start loading it safely, then you will heal that tissue better, which is why we're making these recommendations here. And this is just a sample step over squat. This is a Cossack squat, actually a pretty difficult action to do. I wouldn't do that later. And especially once you turn the foot up, it goes more into the hamstrings, but still not a bad action as a more advanced exercise. And then you can start doing loaded movements as well. Again, the kettlebell here is in the right hand, so it's going to load more with the right leg, but stepping out is a good adductor stretch and a good exercise for you to continue as part of that rehab, part of that development of strength and empowerment. So again, remembering education, empowerment, exercise, and then our supporting manual therapies on top of that. So that takes you through these fantastic groin strains, pretty common injury, pretty easy to deal with, and hopefully you will have lots of success in practice as well. All right. Thank you very much for your time.